like to welcome everybody to this presentation of Fit to a T. So Fit to a T is a program put out by the U.S. Bone and Joint Initiative, which is a federal program to educate people on bone health. So this program has been recently revamped and updated with the latest information. They have some other public health programs on arthritis as well. This one is about osteoporosis. I'm going to start with just a really cute little, it's like a 6-7 minute video that kind of leads us into our PowerPoint. This is actually from their website. We're going to share. Oh, and it's going to get big. And here we go. I'm going to start us in the beginning.
Sylvia groans with frustration and pain, wishing she could join her family on their canoe trip. Instead, she's recovering from a broken wrist. Sylvia can't even console herself with a cool injury story. Her wrist didn't break during an exciting adventure. She just tripped over the kitchen rug. Now, her healthcare professionals say she has osteoporosis, a disease of weakened bones. She's only 53. And at risk for more fractures. Between worrying about her children, her aging parents, her history of breast cancer, Sylvia never even considered her bone health. Doesn't osteoporosis only affect the elderly and Caucasians? How did this happen? Could it have been avoided? When it comes to bone health, the question isn't whether you're at risk of breaking a bone, but rather how much risk. Weak bones aren't limited by ethnicity, sex, or even age. 1 in 2 women and 1 in 4 men will get osteoporosis and are therefore at much greater risk of breaking bones repeatedly and suffering loss of independence. Called the silent disease, you may not know you have osteoporosis until you break a bone. As a Hispanic woman in her early 50s, Sylvia assumed she wouldn't be affected. But if she'd considered what might weaken her bones, she'd have realized how high her risk actually was. She could have strengthened her bones to avoid her broken wrist, and she can still lower her risk of future breaks. It's never too early to start strengthening your bones. The loss of bone leading to breaks happens over a lifetime. Your bone gets stronger during childhood and adolescence, reaching peak bone mass by your early 20s. As you age, your bones start becoming weaker. Your healthcare professional can explain ways to slow this process and strengthen your bones at any age. Many people don't reach and keep peak bone mass because of foods they avoid, lack of exercise, other health conditions, or medications. They're more likely to develop weak bones, even at a young age. As a teenager, Sylvia worried about her weight and often drank coffee instead of milk. She preferred French fries over broccoli. Sylvia didn't realize what she ate had such an impact, but a few changes to her diet could have made her bones stronger. Calcium is key to building strong bones, and vitamin D helps our bodies absorb calcium. Sylvia and her husband now plan family meals with this in mind. Her osteoporosis indicates their children have a higher risk of developing the disease. Growing strong bones and forming healthy habits now helps lower their risk. Building a career and caring for a family is exhausting. Most evenings after the kids were in bed, Sylvia collapsed in front of the TV, sometimes consuming 3 to 4 alcoholic drinks in an evening. If she could go back, she'd limit her drinking to 1 glass and go for a walk instead of zoning out on the couch. Bones become stronger when used. Sylvia wasn't interested in sports, but weight-bearing exercise like walking helps keep bones healthy and strong. Smoking and excessive alcohol consumption can damage bone cells, increasing the risk of weakened bones. Sylvia's dad, George, fell and broke his hip last year, and Sylvia worries he'll never be able to get back to all the activities he enjoyed. George blamed his broken hip on the icy front step. As Sylvia learns more about why bones break, She realizes weak bones were really the underlying culprit. Once his hip healed, George insisted he felt fine and stopped taking his medication. But just because his fracture healed doesn't mean his bones are in better condition. Sylvia urges George to talk to his doctor about restarting his medication and learn a few simple exercises to improve his balance and lower his risk of another fall. It took a broken bone to teach Sylvia the importance of thinking about bone health. Making a few simple lifestyle changes might have spared her the expense, pain, days off work, and limitations she's experiencing now. Not to mention, those same lifestyle changes would also improve her health in other areas. But Sylvia's story isn't over. Her healthcare professionals obtained a test to assess her bone density and determine her risk of more fractures. She's working with them to reduce her risk through medication, diet, fall prevention, and regular exercise. What is your risk for breaking a bone? What steps can you take to make your bones stronger? This video is brought to you by the United States Bone and Joint Initiative. Our Fit to a T programs provide opportunities to meet with healthcare professionals to learn about assessing and reducing your risk of weakened bones, as well as the latest advances in knowledge about this disease. Visit fit2t.org to learn more and organize a Fit to a T session in your community.
Okay, so now we're going to go into our PowerPoint. That was kind of like an introduction. I just thought it was cute. It's fun to watch how they draw it out. It keeps your attention, I think. All right, so now I'm going to share my PowerPoint. Okay, but this is Fit to a T. This is by the U.S. Bone and Joint Initiative. And we started with our little video. So we met Sylvia and her father Darius, all right, and her osteoporosis. So our first slide here is, which is the bone with osteoporosis? So osteoporosis is weak bone, or it has decreased density, porous, porosis porous, okay? Osteopenia is weaker bone, but it is not as porous as osteoporosis. So you have low bone mass, but you haven't hit that level of osteoporosis. And the guideline, or the little marker that they use for osteoporosis, is minus 2.5 standard deviations below what they feel is normal bone mass, okay? All right, one of the confusing things that people have is the difference between osteoarthritis and osteoporosis. Osteoarthritis is degenerative changes within the joint. Osteoporosis is low bone density. Osteoarthritis can be painful. Osteoporosis by itself is not painful. It's called a silent disease because you do not have pain until you have fractures or issues. All right, so this is just looking at the life of your bones. Okay, we get our peak bone mass at about 20 years. So up to those first, 20 years, we're laying down bone. And then at 20, it kind of slows down and it stays fairly level until we kind of hit menopause. And once we hit menopause, we start to have a more rapid bone loss. And then once we're into our, 70s, 80s, and 90s, it's a little less rapid. Family history, gender, race are responsible for the majority of our bone mass, but diet and exercise are responsible for up to 25% of our bone mass. So honestly, the people that should be watching this are people in their 20s or even in their teens, because you want to be building up bone mass. It's almost like a bank account. Like if you have a lot of money in your bank account to start, like when you're 20 years old, if you keep withdrawing throughout your life and you still have a lot of money, you're doing well. If you start out with very little money, once you start withdrawing it, you're in trouble. So it's really in those teen and early 20s that you need all the things that build up good bones in that bone savings account. And because 25% is diet and exercise, you definitely, can impact that. All right, which bones break off most often? So this is considered the silent disease until you break a bone. The three areas that people tend to fracture are vertebral, like compression fractures, hip fractures and wrist fractures. And I think a lot of, like for wrist fractures, people always are falling and you put your hand out to stop the fall. With hip fractures, it can be from a fall. Also, it's thought that if you can see, like on the, yeah, here we are, like this is the, like the neck of the femur. Anyway, sometimes when people have a lot of osteoporosis in here, just even this gives way and it results in a fall. So people will be standing still, not necessarily tripping, but their hip will break and they will fall to the ground. We have 2 million low impact fractures a year. Okay, and of those, vertebral fractures make up 27 to 34%. Wrist fractures are 12 to 20%, hip fractures 15%, and pelvic fractures 7%. And when somebody has a low impact fracture, then that's usually a sign that we need to look into bone density. All right, what are some risk factors? Okay, some of the risk factors you can change, some of them you can't. Okay, you cannot change your ethnicity, family history necessarily, but you can change some of the habits. All right, and you can still have osteoporosis without any risk factors, familial or genetic or ethnicity. So the things that, you know, that are variable that you can change are your calcium and vitamin D intake. If it's vitamin D3. Some other things that you don't have control over are comorbid conditions such as breast cancer. A lot of times when people have breast cancer, they're taking medications that reduce their estrogen levels. Also sometimes just treatments for other treatments for breast cancer. You can change lifestyle habits, sedentary, smoking, a lot of alcohol intake, all changeable. Age, sex, you know, body size, family history are a little harder to change, as well are race and ethnicity. Okay. All right, why did the fracture happen? Well, she fell over the cat, that's one thing. But people who suffer from a fracture that have osteopenia or osteoporosis are at higher risk for subsequent fractures. So people who have a low impact fracture, which means they're not in a major motor vehicle accident, like it's not a huge trauma, they should have follow-up care and look into prevention measures, okay? People who are over 65 can be tested and treated for osteoporosis, and this is covered by Medicare. All right. What are the consequences of a fracture? Okay, so obviously there's a hospitalization there on the screen on the left. So there are medical consequences. I mean, fractures can lead to hospitalizations. Some fractures with hospitalizations and other comorbidities lead to death. With vertebral fractures, we can have a loss of height. You can have a change in your posture. The original Fosamax commercial had the woman going for the train, and she was quite bent over, which was showing she was having compression fractures in her spine. And instead of looking kind of like a cube, your cube becomes a wedge, like angled. And when you have one wedge on top of another wedge on top of another wedge, people start bending forward. Fractures can lead to a loss of independence because you're less mobile. It also can affect mental health. People become depressed when they lose their independence. So physical exercise, nutrition, and some medications can help prevent these negative consequences. All right, so how, you know, fractures are preventable. Like, how can we prevent them? Fall prevention programs, things that work on balance and strengthening. Fracture risk assessment. So, and it'll be in another slide too, but besides a T-score, there's something called a FRAX. It's like a fracture risk assessment. You can just Google FRAX online and like, it'll come up and you fill in the little answers and it gives you a FRAX score. So that's your risk of fracture based on your medical history and other familial things that kind of come into that equation. Getting tested with a DEXA scan will show your density. Having adequate calcium and D3, appropriate diet, making sure physical activity so that what you can affect, you are affecting, and then medications if it is appropriate. Okay. All right, preventing falls. Okay, 1 in 4 Americans over the age of 65 fall each year. Falls are costly. About 3 million Elders are treated in the ER from falls, and 800,000 of those are admitted annually, and 300 of those are from hip fractures. Falling is not an inevitable part of aging. Although it's commonly seen with aging, it is not inevitable. So you can have a fall risk assessment by a physical therapist. Interventions for balance, such as Tai Chi and strengthening. There are definitely some comorbid risk factors, like people with impaired gait, people with joint problems, sensory impairment. When people don't feel where their feet are, it's hard to tell when something's, uneven. Cognitive issues, orthostatic hypotension, that is where a person's blood pressure changes and drops when they stand. So if you go from sitting to standing, a blood pressure drop, and then people tend to like pass out or fall. I always tell people stand and then count to 3 before you take your first step, just to kind of get your bearings. Different medications may make you more at risk for fall if they affect your blood pressure or affect dizziness, overall weakness, and then environmental hazards. So there are some, definite things in the environment. Always make sure you're wearing good shoes that are, fitted and not like half on and off your foot, good supportive shoes. At home, throw rugs can be an issue. You want to make sure any area rugs are adhered down or have rubber underneath. You do not want any rugs that do not have a rubber backing. And in general, rugs, especially if it's a big change in height, can be a tripping hazard, something to be aware of. Night lights during the night, so your paths are well lit. I've seen many people that have tripped over their pet in the middle of the night on the way to the bathroom because the pet moves, and you kind of know where everything is in your house, so you don't almost have to see. But when that pet moves, people will fall over the pet. Night lights are another, big thing. And you want to make sure that things are up off the ground. At the time, I've done home health in the past, and sometimes you go into homes and there's only narrow walkways, like because there's magazines on the sides or boxes or different things. You definitely want things up and off the ground. All right. All right, measuring your bone mineral density. We mentioned the DEXA scan before. So the DEXA scan is a type of x-ray that they do that looks at different bones. So they will look at your hip and spine. Sometimes they will look at a person's wrist. They're looking at, so there's a T-score and a Z-score. But the T-score is looking at your bone density as to what they consider norm. And I think that norm is of like a 30-year-old or something. So as we age, we tend to have a kind of negative score. But when it gets minus 2.5, then that is considered osteoporosis, and that becomes a concern. So normals above minus 1.0, and again, that's, standard deviations below what they consider norm. And then there's the FRAC score, which is looking at your risk of fracture, that also considers drinking, like alcohol intake, smoking, family history, your weight, your height, your age, etc. Because not only is it bone density sometimes, but it's the quality of your bone, which is maybe a little harder to measure. All right, so calcium. Let's talk a little bit about calcium. So calcium is important for bones. So think of it, something 99% of the calcium is in your bones and teeth. So if your body is lacking calcium, it's going to take that calcium from your bones and teeth. So you don't want that to happen. So you want to make sure you have adequate calcium in your system. All right, so it's calcium in D3. You always want to discuss supplements with your doctors to make sure they're not interacting with certain medications and what the appropriate supplement is for you. Intake varies depending on what the supplement is. For example, calcium carbonate is a supplement you take with meals, but calcium citrate you can take anytime. Some people have difficulty with calcium carbonate, tends to be a little constipating. Calcium citrate sometimes tends to be a little easier for that reason. But your body can only absorb 300 to 500 milligrams of calcium at a time. So that's another thing to think of. So sometimes people take supplements, but they're not absorbing everything they're taking. So they think they're taking a lot, but they're not really. So obviously, if you're only taking 300 to 500 milligrams of calcium at a time, it's better to have your supplements twice a day, or in your diet, have it broken up so that I'm getting calcium in parts throughout the day as opposed to one, mega dose. According to NIH, if you're under 50, it's 1,000 milligrams of calcium a day. Over 50, it's 1,200 milligrams of calcium a day. I've also read other things that people are questioning. That was a study that I think was relatively small. And I was reading one doctor saying, well, I really don't think you need as much as they say. But that right now is kind of the guideline by NIH. And the upper limit for calcium intake is 2,000 milligrams a day. So you also do not want to take too much of a supplement. Calcium is measured in milligrams. And then D is in units, international units. We'll go to that in a minute. Calcium-rich foods, it's always good to get, nutrients, calcium, etc. through diet. So dairy products, yogurt, cheese, milk, regular low-fat or skim. Milk fortified with calcium is 500 milligrams of calcium per 8 ounces of milk. All right. Canned sardines with bones, 3 ounces of sardines are 375 milligrams of calcium. Salmon and anchovies are also good sources of calcium. Fortified orange juice is 500 milligrams of calcium per 8 ounces of juice. Many years ago, I was in a conference and they talked about calcium, and I think your body is able to absorb more calcium from the orange juice than from the milk, because the orange juice is a little acidic, and the more acidic your stomach is, apparently the better it absorbs nutrients. So for people who are taking a ton of Tums a day and then taking their vitamin with it, they don't absorb as much. Green leafy vegetables such as broccoli, a cup of fresh cooked broccoli is 175 milligrams of calcium, and dark leafy greens such as turnips and mustard greens and collard greens add calcium. So in food labels that show calcium, it's a percent of 1,000 milligrams per day. So if the label says it's 20% of the daily calcium requirement, it's 200 milligrams. And if it was 15% of your daily calcium requirement, it would be 150 milligrams, okay? So that's how you know, and it's per 8 ounces, okay? So depending on how much you're drinking or eating in that size, it would change that intake. It is a little confusing with supplements because some things are milligrams, some things are international units, but all right, so now vitamin D. Vitamin D3 is needed for your body to absorb calcium, but it's a little more difficult to take through food sources. You get D3 when you're in the sun for about, 10 minutes per day? Yeah, 10 minutes a day, produced when your skin isn't, but now that we're all with sunscreen, clothing limits that absorption, because people with darker skin absorb less D3. So you want to make sure, especially if you're not in the sun, that you're getting adequate D3 either through your foods or supplements. D3 is found in eggs, fish, liver, and fortified dairy products and orange juice. You need 600 to 1,000 units of D3 per day, and they can do blood tests to look at your levels of D3. Too much D3 is toxic though, so you want to discuss any supplements with your doctor. And also be wary of what you're taking in your diet. All right, older people are less able to create D3 even when exposed to the sun. So the older you get, the harder it is to create D3, which is why as we get older, we may all have lower levels of D3, and darker skinned individuals absorb less D3. All right, so weight bearing, physical activity, and exercise. So the diagram here is pretty good. The smiley bone is showing things that are a little more impactful and are better for bone building. The middle, not smiling, not frowning bone, are things that are okay, but not as much bone building. So that's swimming and bicycling because they're not impact sports or activities. But I always say any exercise where muscles are pulling on bone is positive. So if that is all you can do, it is still better than doing nothing, which is Sylvia on the couch smoking and drinking and watching TV. So exercise builds bone mass, it decreases your risk of falls, it increases your strength, and it increases your balance and flexibility. And it's all, you have cardiovascular positives with it, and people have less depression with exercise. So weight-bearing exercises and resistance exercises are the most bone building. If you have been diagnosed with osteoporosis, you are to avoid flexion and twisting, and it's recommended you always keep one foot on the ground to minimize your risk of falls at all times. And if you're doing resistance exercises, what the research has shown is that you should be gradually progressing your exercises. So I said, like if you're doing a bicep curl with 1 pound, you know, if you do it for the whole year at 1 pound, it's not as helpful as if you can gradually increase that resistance. All right. But again, doing something where your muscle pulls is better than doing nothing. All right. How do medications work to strengthen bones? Okay. There are different medications out there. They basically work by either building bone up or stopping the reabsorption of bone. That's basically the two ways they work. So you have osteoblasts and osteoclasts in your body. These are cells. The osteoblasts create bone and lay bone down, and the osteoclasts eat bone away or remodel bone. So when somebody has a fracture and the fracture heals, you get a whole, like if you looked at it at x-ray, you get like a little lump. And what happens is you get this like almost like a bony callus. You lay all this bone down, and then through weight bearing and pressure, your body remodels that bone. And the bone you don't need, the osteoclasts eat away, and you kind of then have a normal looking bone or a better looking bone. All right, so when do people get medications? So there are certain guidelines that dictate whether a person receives medication or not. So let's see, there's FDA approved drugs for women and men over 50 who meet one or more of the following criteria, which is a history of a hip or spinal fracture, a T-score less than -2.5 at the hip or spine, a T-score of -1 to -2.5, so that's the osteopenia range, at the hip or spine, indicating low bone mass, plus a 10-year FRAX estimate of greater than 20% for major osteoporosis related fracture or greater than 3% for hip fracture. So if you have osteopenia and they do the FRAX score and you come out as a high risk, that may also qualify for medication, all right? So the two basic approaches are slowing down the reabsorption of bone, so anti-reabsorptives, or anabolic, which builds bone, okay? All right, and yes, so the goal of the medication is to increase bone strength or improve the stability of bone and reduce your risk of fracture. All right, so what are some of the red flags? So red flags are concerns, things, a younger postmenopausal woman. So if you have menopause at a young age and you're not getting as much estrogen overall, which helps, estrogen helps with bones. So, but also women on certain medications, steroids, chemotherapy, immunosuppressants, some anticonvulsants, all kind of affect bone density. Thyroid medication is another thing that may impact bone density. Men also get osteoporosis. They tend to suffer from osteoporosis-related fractures about 10 years later in life than women. But the consequences are greater with men, having twice the 1-year fatality rate after a hip fracture. So you know, they tend to have less fractures or have them later in life, but tend to have more morbidity after that. Men at high risk for fracture also had a fragility factor, oral steroids, and then treatment for prostate cancer with androgen deprivation. Okay. So for younger premenopausal women, there are some secondary causes for osteoporosis, which include medications and endocrine disorders, malnutrition, malabsorption. Women who have had eating disorders, or athletes with that, it's like the female triad syndrome. It's where people are exercising so much, they're not getting their period, or they're very low in their weight. All that can affect bone density and impact you later in life, or even during that. You can also see stress fractures from women with the female triad. All right, and okay. All right, and so scientific studies have concluded men and women, usually older men, with comorbidities are at an increased risk of fracture, and these comorbidities include breast cancer, diabetes, COPD, strokes, renal failure, HIV infection, and dementia. Okay. All right, or some of the comorbidities. Ethnicity and osteoporosis. So you tend to see osteoporosis more in Asian and Caucasian women, but it doesn't mean it doesn't happen in other ethnicities. Hispanics appear to be more at a risk than were initially realized. Over 50% of women over 50 have experienced bone loss and partially some of that is because they consume less calcium due to lactose intolerance and less exercise seen in Hispanic women. 5% of African American women have osteoporosis, but they're more likely to die from a fracture due to other comorbid health conditions. And 80 to 90% of fractures in African American women are related to osteoporosis. And this is just acknowledging U.S. Bone and Joint Initiative, Fit to a T, who provided this information.